Understanding oxygen supply and tissue demands will give us a deep explanation about the oxygen monitoring. So tissue oxygenation depends on the FiO2, the inspired partial pressure of oxygen, the PO2, alveolar oxygen tension, PaO2, arterial oxygenation, oxygen delivery, tissue perfusion, and oxygen uptake. But before we go deep into the discussion, let us recall on how the respiration happens inside the body. As we breathe in air, we are inhaling 21% of oxygen, 78% of nitrogen, and the remaining tracer gases. It will progress into the lungs. From the lungs, it will go to the acinus. From the acinus, oxygen will then diffuse in the arterial blood and to the hemoglobin carried by the RBC or the red blood cell. The hemoglobin passes through the tissue cell. It will release oxygen and absorb carbon dioxide in the process internal respiration and metabolism. From the venous blood, oxygen is ready to be released via exhalation that will pass through the lungs and to the mouth. On your screen is the direct representation of what I'm trying to explain earlier. So the oxygen status is determined by examining the PaO2, arterial oxygen saturation, and the arterial oxygen content. The PaO2 represents the partial pressure of oxygen dissolved in the plasma of the arterial blood and is the result of gas exchange between the lungs and the blood. The PaO2 also is reduced in various settings, but most often when lung disease is present. A range of less than 40 millimeters of mercury is called severe hypoxemia. Range of 40 to 59 millimeters of mercury is called moderate hypoxemia, and the PaO2 range of 60 to the predicted normal is called mild hypoxemia. The amount of oxygen used by the tissues in the body is called oxygen consumption. Oxygen consumption is determined by three factors: the oxygen demand, oxygen delivery, and oxygen transport. In relative terms, the cell's requirement of oxygen requires timely, efficient delivery of adequate supplies of oxygen. So normal oxygen consumption ranges from 200 to 240 ml of oxygen per minute. So arterial oxygen delivery. The amount of oxygen transported to the tissue depends on two factors: the arterial oxygen content as reflected from the total amount of oxygen in the blood that is available at the cellular level, and number two, the cardiac output defined as the amount of blood pumped out of the heart per minute. So normal DaO2 or the arterial oxygen delivery ranges from 900 to 1000 ml of oxygen per minute. So venous oxygen reserve. Venous oxygen reserve, RVO2, is the amount of oxygen left over which is not used by the body tissue that returns to the heart in venous blood. So the RVO2 depends on two factors. Number one, we have the arterial oxygen delivery or the DaO2. And number two is the oxygen consumption. So normal RVO2 ranges from 700 to 800 ml of oxygen per minute. So moving forward, we are going to talk about the oxygen dissociation curve. Hemoglobin saturation with oxygen varies with changes in PO2. This curve is composed of an upper flat portion and a lower steep portion with a PO2 of 60 millimeters of mercury and saturation of 90%, marking the dividing point between the two. On the flat portion, as the PaO2 drops 40 mmHg from 100 down to 60, the saturation decreases very little, by only about 5 to 7%. On the other hand, when the PaO2 falls below 60 mmHg into the steep portion of the curve, saturation decrease is much more precipitous. For example, on the portion of the curve, a decrease in PaO2 of only 20 mmHg from 60 to 40 mmHg causes a 15 to 20% drop in SaO2. The following are the influencing factors affecting the oxyhemoglobin dissociation curve. So, a shift to the left is made possible if there's an increase in pH, decrease in carbon dioxide, in body temperature, in 2,3-diphosphoglycerate or 2,3-DPG, and if there is a fetal hemoglobin and these hemoglobins. A shift to the right will appear if the pH is decreased and increased PCO2, body temperature, 2,3-diphosphoglycerate. Those are the factors affecting the curve. Generally, there are two modes of getting the oxygen content of the patient. Number one is invasive via an indwelling catheter, and number two is non-invasive by using a pulse oximetry. Indwelling catheters, such as arterial and central venous pressure and pulmonary artery lines, provides a ready access for blood sampling and allow continuous monitoring of the vascular pressures without the traumatic risk associated with repetitive percutaneous punctures. However, infection and thrombosis are more likely with indwelling catheters than with intermittent puncture. The most route for an indwelling arterial vascular line is the radial artery. Less commonly used site are the dorsalis pedis, brachial, axillary, and femoral arteries.